a young person has both an intellectual developmental disorder and mental health concerns. And you'll notice from the cover slide that I put on for your information, the NAD website. We'll have occasion to talk about that again briefly later. But the NAD is the organization, a national, actually international, that really is dedicated to the mental health concerns and needs of individuals of all ages with intellectual and developmental disorders. I want to encourage you, if you have the opportunity, to visit that website, to do so, and you'll find there a wealth of opportunities for continuing education as well as just information, pertinent information. So what are our objectives for today's session, or at least my presentation portion of the session? Well, one is I want to just identify some of the mental health concerns of youth with IDD that have probably come to your attention. They certainly have come to my attention. I want to also review some of the promising practices and approaches that have been used effectively with youth with IDD and their families. And you'll notice I'm using promising practices because the literature is pretty sparse on what might actually be evidence-based practices for youth with IDD. However, we do have some indications of what may be effective in working with young people and their families. And then along the way, we're going to consider strategies, approaches, and tools we can use to build towards equity and parity of mental health services for youth with IDD, given our current resources. So here's the spoiler alert. Those of you who are trained as clinicians, you already have a considerable amount of skill which is needed to work with this population. And I want to encourage you to think about how you can apply your skills. This is an underserved population. So a little bit about Oregonian children and youth with special needs. About 1 in 5, or 19%, of Oregon's children younger than 18 are identified as having a special health care need. Approximately 18% of them are white non-Hispanic, 17.5% are Hispanic, and approximately 14% are ages birth through 5. That represents 14% of this population of children and youth with special needs. That's 17% are ages 6 through 11, and 25% are ages 12 through 17. And probably are beginning to look at what we might consider transitional age youth, or heading in the direction of. So many of these children live with two-parent families. About 63% are in two-parent family, married families, 8% in two-parent unmarried families, and about 20% in a family headed by a single mother, and 8% live in a family with another structure type. So if you're interested in getting some more information about the stats with regards to this group, you can click on the link that I provided at the bottom of this slide. So a little bit about intellectual and developmental disorder, also known as intellectual disability. And you'll notice that I said as defined by Oregon state government. And this has to do with what would render somebody eligible for services. Now, I want to point out that states vary in terms of their cutoff point for what they consider to be an IQ that is substandard enough to warrant eligibility for DD services for that state. So for the state of Oregon, sub-average intellectual function, seem to have some kind of echo going here, with an intelligent quotient, an IQ of 70, and under. And it's measured by standard IQ tests like the Stanford-Binet, the Wechsler test. Those are pretty much the standards used by professionals to measure intellectual quotient. However, it's not enough to have substandard intelligence in order to be considered intellectually disabled or having an intellectual developmental disorder. You also must show a lack of daily living skills, or what we call adaptive behavior or adaptive behavior skills, such as, but not limited to, problems with communication, problems with self-care, such as in grooming, dressing, toileting, showering, safety and social skills. And that usually shows up for individuals with intellectual disability before the age of 18. However, individuals with IQs that are a little higher than 70, 71 to 75, may also be considered to have an intellectual disability if there's a significant impairment in their adaptive behavior, as is identified by a licensed clinical or school psychologist. So again, for a full definition of how Oregon defines intellectual disability, you might want to click on the link that is provided in this slide. So a developmental disability is not only intellectual, there are other types of developmental disorders. So usually a developmental disability is a severe mental or physical impairment or combination of mental and physical impairments. However, mental health, so this could be a little confusing because they don't mean mental health concerns. They mean more cognitive ability than mental health. It begins usually before an individual is 22 years of age. In other words, it happens during what we consider the developmental period. For individuals with intellectual disabilities, I previously mentioned, it's before the age of 18. And it directly affects the brain and it continued to affect the brain indefinitely. In other words, this is not a condition that somebody recovers from. They may gain skills, they may be able to cope effectively given limitations, but the brain behavior connection is lifelong. And it causes significant impairment in activities of daily living, adaptive behaviors, also known as ADLs, such as previously mentioned with ID, in self-help skills, learning, communication, living independently, working, and being economically self-sufficient. And developmental disabilities, in addition to intellectual disability, may include autism, cerebral palsy, epilepsy, or other neurologically disabling conditions. So for instance, an individual who has sustained a traumatic brain injury before the age of 22 may well be considered eligible for developmental disability services because they sustained the injury before the age of 22, and the problems that they will have will be considered lifelong. By the way, it used to be thought that everybody on the autism spectrum was intellectually disabled. We now know differently. Most individuals who are on the autism spectrum are either an average or above average range of intellectual functioning. And so autism, we refer to as autism spectrum disorder, does come in terms of a variety of grades of severity, which would also include the possibility of different levels of intellectual functioning. So for a full definition of developmental disability, I refer you to the relevant statute that is listed. That is a link on that slide. So intellectual and neurodevelopmental disorders represents really a heterogeneous population of individuals. I mean, we tend to think or talk about this group as if this was a homogeneous group of individuals who all had the same kind of conditions, but that is not true. It's a very diverse group of individuals. Some have intellectual disability, others do not. Some are on the autism spectrum. Some may have cerebral palsy or seizure disorder or other brain disorders that begin in childhood and are lifelong. And there are people who have a combination of developmental disorders. So they may have autism as well as intellectual disability. They may have Down syndrome as well as be on the autism spectrum. So there are a variety of ways in which these developmental disorders may be present. But they all challenge the individual's ability to communicate, problem solve, learn from their experience, cope with stressors, sustain meaningful relationships, succeed at school, obtain meaningful employment or day activity, live independently, manage one's own affairs, and become economically self-sufficient. So it's impactful on an array of life domains. And this is something to keep in mind as we think about what the mental health concerns of youth with IDD might be. So what are some of the unique challenges of youth with IDD? Well, for our general youth, our typically developing youth with mental health concerns, we usually think of them as having some buffers or protective factors that we look to in terms of mitigating the effect of mental health issues. So for typically developing individuals, that might be that they have friends or family that are social supports, or that they do well academically, or school is a setting where they have some feeling of success as opposed to other areas of their life, or that they will eventually have some prospect for employment. So this is particularly pertinent for those youth who are in transition into adulthood, whom we call TAYS. However, for youth with IDD, we can't presume the same protective factors operate for them. Their social supports may be minimal or non-existent. They may not do well in a school setting, and that may not be an area where they can experience success. And that they may, be aging into a period where they have limited prospects for employment. So again, looking at that transition age population, the TAYS, who are normally considered within the ages of 16 to 25. Now, youth with disabilities have complex and individual support needs that, if unmet, can limit their long-term outcomes throughout adulthood. So one of the messages that I hope you get as a result of my presenting to you today is the idea that the earlier one intervenes with youth with IDD, the better are the expected outcomes. And that may seem obvious, but really that's not how we organize services usually for children with IDD. I mean, there's hardly any attention to childhood mental health problems for children that have intellectual or developmental disorders. So descriptive studies reveal that children with disabilities fall behind their peers who do not have disabilities as they transition to adulthood, particularly in achieving post-secondary education. Many of them are not going on past high school or however long they are in school, and their employment outcomes are not very promising. So if you have not seen this material from North Carolina, complex MHIDD, I've provided a link. It is pretty comprehensive look at different aspects of mental health concerns of youth with IDD. And I really recommend that you look at it. This particular link was probably going to give you some ideas about how to adapt cognitive behavior therapy for the population of youth with IDD. But the complex MHIDD-NC.org website itself has numerous resources pertinent to mental health concerns of youth with IDD. So one area, so one of the messages that I want to bring to you is some of the things that are challenging youth with IDD challenge youth without IDD. And so some of the lessons we've learned in how to treat typically developing youth that have been, for instance, exposed to trauma could be pertinent for the population of kids with IDD with some modifications. So youth with intellectual developmental disabilities are more vulnerable to the range of behavioral, social, and emotional difficulties throughout life and may have co-occurring disorders, including those related to trauma exposure. And one of the best resources is the National Child Trauma Network. And so here's the link. And they, in fact, have a series of fact sheets as well as a toolkit pertinent to trauma and IDD. So if you are working with children that have been trauma exposed, or there's some suspicion that they have been trauma exposed, and for some kids with IDD, they have numerous medical procedures. It might not be sexual or aggressive, neglect or abuse, but it might be that their IDD, their neurodevelopmental condition, comes with it multiple surgeries, medical procedures, and they have experienced medical trauma or trauma having to do with how their health care has been provided to them. So again, the tool through the National Child Trauma Network is very valuable to give you a kind of rounded idea of ways of approaching trauma and IDD. Okay. And there is a core curriculum on childhood trauma through the National Child Trauma Stress Network. So again, if you're visiting that website, you'll see it is for free. And there are a number of modules that you can take relevant to trauma and intellectual developmental disorder. Another major area that we see for the typically developing population that we see among youth with IDD is substance use and substance abuse. So people with intellectual disabilities suffer disproportionately from substance use problems due to the lack of empirical evidence to inform prevention and treatment efforts for them. There's just not a lot of research being done with regards to youth with IDD who are using substances. Past research suggests the prevalence of alcohol and illicit drug use is relatively low among youth with IDD, but the risk of abuse is relatively high among those kids who do use substances. In other words, the use of alcohol and drugs is not prevalent. However, among those who do use, there is a higher chance of this becoming a substance abuse situation. Review findings suggest that the past month's prevalence of illicit drug use is lower among people with ID, but the rates of legal substance use tend to be similar to those in the general population. Some individuals with ID may have greater exposure to substance use when compared to others with ID, especially those with mild ID or borderline intelligence and co-occurring mental health disorder, and those who are incarcerated. Well-designed studies are needed to discern the base rates of substance use among people with ID and form prevention and treatment efforts. In most substance abuse or substance use programs, it is difficult for youth with IDD to get treatment. That is the same that's true for adults with IDD. There have been models in which there are specialized tracks for individuals with intellectual and developmental disorders to receive treatment. Suicide rates are rising among typically developing as well as youth who have IDD. And individuals with IDD or those with autism are at higher risk for being victims of bullying and social rejection which seem to be associated with higher risk of suicidal thoughts and behaviors. And autistic individuals have higher rates of underemployment or unemployment than the general population. Youth and adults on the autism spectrum have higher rates of mental health concerns, such as depression, bipolar disorder, schizophrenia, anxiety, and ADHD than other people of their age without those concerns. We know that the rate of mental health concerns among individuals with IDD is fairly high. So the social media issue, which we are concerned about with regard to our youth in general, is of concern with individuals, youth with IDD. So there's the good news and the bad news about this. The good news is that for those young people who have difficulty engaging in person or connecting with others because of poor social skills or difficulty tolerating or accessing in-person social opportunities, this is a way to remain connected. The bad news is that youth with IDD are in particular vulnerable to online exploitation by their peers and adults who do not have their best interests in mind, and very little cyber protection for youth with IDD, or generally for youth who get onto social media. And then an issue that has been raised, particularly with regards to youth who are on the autism spectrum, is the idea of gender dysphoria. There's some discussion that that individuals on the autism spectrum might be more likely to experience gender dysphoria than people with other disabilities or individuals who do not have disabilities. So what is it? It's that the youth may experience discomfort when their assigned sex is different from the gender they identify with. That is what we mean by gender dysphoria. There's some evidence to show a link between gender dysphoria and autism, and that autistic people may be more likely, as I said. However, there's little evidence about the reasons why, and some recent research suggests the link between autism and gender dysphoria may not be so clear. More research is needed to develop and test, support, and treat individuals who do experience gender dysphoria. So let's go back to this idea of what may be most challenging for youth with IDD with regards to recognizing and addressing their mental health concerns. One is this idea of diagnostic overshadowing, which I'm going to get to in a future slide. The other is that assessment may be difficult because youth with IDD may have communication deficits. That part of their developmental disorder may result in language problems that make it difficult for them to express how they feel and have others understand when they are having mental health problems. We have a shortage of professionals who are knowledgeable about mental health and IDD, and I'm hoping talking to you as a group will be one way for us to bridge that as I try to convince you that you have the skills that you need in order to work with this underserved population. You just need to be aware of some of their unique challenges and keep up to date with some modifications in approaches. So there's a lack of cross-agency and cross-department collaboration within state government and on the county level, so that mental health agencies and disability agencies very often are not cooperating with one another in order to find the best mix of services for youth with IDD and mental health concerns. Few studies track prevalence of mental health concerns, so we really don't have accurate statistics on youth with IDD who have mental health disorders. And challenging behaviors, which is usually why and how a youth first comes to anyone's attention, may be mistakenly attributed to psychiatric illness when it may not have anything to do with psychiatric illness. So we have the phenomenon of either the child does not get a diagnosis when they need one, or may be misdiagnosed, or may be given a psychiatric diagnosis when one is not warranted. And some recommendations can be found out of the University of Texas policy recommendations, and I provided the link for that and the slide on challenges here. So additionally, the lack of standardized measures to assess mental health concerns makes it difficult to do an accurate, comprehensive mental status workup for some of the youth with IDD. Unfortunately, in the field, there is a tendency to use medications to address behaviors rather than psychiatric issues. So really, medication should be addressing psychiatric problems, and behavioral intervention should be used to address behavioral problems. But sometimes we see that medication is used for behavior instead of psychosocial interventions. And the failure to identify the impact of adverse childhood events on youth with IDD, a number of them have, as I said, had traumatic exposure, and there doesn't seem to be an appropriate consideration of that as we think about their presentation as youth with possible mental health concerns. Again, this is taken from the University of Texas, Austin, and some of the work that they've done. So I wanted to go back to this idea of diagnostic overshadowing. What do I mean by that? I mean that once you are labeled with something, like once the child is labeled with having an intellectual or developmental disorder, everything about them is about their IDD. And of course, that's not the case, but unfortunately, it's sometimes hard for people to look beyond that. So it can obscure features of mental health disorder and result in a child not getting a diagnosis when they should get one, or getting an incorrect diagnosis of mental health concerns, or being diagnosed with something when they shouldn't be diagnosed, as I said previously. It could also obscure features of neurodevelopmental disorder because. So for instance, let's look at this issue of behavioral or emotional dysregulation. It is not uncommon for a child or an adolescent on the autism spectrum to have difficulty with emotional or behavioral regulation. Self-monitoring and self-regulation are not particularly well-developed skill sets for youth on the spectrum. However, that could be mistaken for bipolar disorder or some mood disorder, when in fact it may be a function of their neurodevelopmental presentation. Very important, therefore, to know about the neurodevelopmental disorder that the youth has that is presenting to you with possible consideration that they have mental health concerns. So one of the fastest growing segments of the disabled population is individuals on the autism spectrum. And one of the key areas of difficulty for people on with ASD, autism spectrum disorder, is communication and social interaction. So the National Autism Report found that more than 1 in 4 teens with autism had trouble with basic communication. Nearly 70% were able to communicate somewhat or very well about things that really mattered to them. In addition to specific symptoms of autism, people with autism frequently experience other health and mental health conditions. Among teens with autism, they found that 76% had ADHD, anxiety, and/or depression. 48% were taking prescription medications for attention, behavior, or mood, and 57% had received mental health treatment or counseling in the previous year. And I have the umbrella that represents autism spectrum disorder, so you can see there are a range of conditions. Asperger's was previously considered a separate diagnosis It is now subsumed under autism spectrum disorders, along with autistic disorder, childhood disintegrative disorder, and Rett's disorder. So youth on the spectrum, there were 5 recommendations for assessment of anxiety. And the reason I'm bringing this up is to say, this is how knowing a neurodevelopmental developmental disorder can help you discern more clearly what a youth with IDD and potential mental health concerns may need. So one is to conduct a developmentally appropriate multi-method assessment. So you want data coming from multiple sources about the child. Evaluate anxiety symptoms related to the core features of ASD. So keep in mind that the child is stress sensitive. There is a hyperreactivity or hyporeactivity that's possible. Talk about that in the next slide. Assess and treat other conditions that may exacerbate anxiety. Address suboptimal behavior and stressors that may contribute to anxiety, and evaluate the degree of anxiety-related impairment recommendations for treatment. So anxiety and depression are the most common diagnoses that you're going to see with youth on the spectrum, for instance. Those are the most prevalent diagnoses. So what is the connection among being on the spectrum, sensory reactivity, and anxiety? Well, sensory reactivity could take either direction, either being hyperreactive, that is over-responsive, like very sensitive to lights and noises and people around you, or it could take the form of a hyporeactivity, that is being under-responsive, seemingly indifferent or impervious to various sensory input. In hyperreactivity, people have extreme responsive to sound, smells, taste, textures, or sights. That can include sensitivity to bright or fluorescent lights, aversion to certain tastes or textures of food, discomfort with even light touch. So again, consider how environment may play a role in whether individuals have stress reactions who are on the spectrum. Under-responsiveness may present a seeming indifference to pain or to heat or cold. Sensory over-responsivity is common in children with autism. About 1/5 of them show that. Anxiety disorders are more common in children with autism than in children without autism. Whereas 19% of typically developing children meet the criteria for anxiety, 40% of children with autism meet the criteria for anxiety. Among young children with sensory over-responsivity, more than 40% also meet criteria for anxiety. So here are some connections between the individual's autism-related sensory responses and the mental health concern of anxiety. And this would be important to know about a youth that is on the spectrum that presents with, to you for treatment or evaluation. So if you want to learn more about autism spectrum disorder in general, there are free online trainings for professionals. I believe the autism internet modules may be an Australian site, but again, it's free and they are very good. And then I'm sharing with you, I'm a member of the California Autism Professional Training and Information Network, CAPTAIN. Both professionals and parents can access modules through that site that will tell you about ways of supporting children on the autism spectrum. So treatment with ASD and mental health concerns, the Autism Treatment Network generated 4 recommendations. Psychoeducation about the fact that youth with ASD can have mental health concerns, and coordination of care with that in mind. Employing modified CBT techniques, and cognitive behavior therapy tends to be the treatment of choice. that is recommended for individuals with ASD. Consider medication, but start with low doses, and refer to a child psychiatrist if the child is not responding to the non-pharmacological interventions. Another group that I think deserves special shout out, especially since next month is Fetal Alcohol Spectrum Disorder Month, is FASD. So like autism, fetal alcohol occurs on a spectrum, with fetal alcohol syndrome being the most severe manifestation. And then there are other ways in which brain behavior can be affected depending on when and how much alcohol was consumed by the mother during pregnancy. So in Oregon's prevalence rate, there are about 48,000 babies born a year, and 1 out of every 2,000 or 24 babies a year are born with FAS, being the most significant form of fetal alcohol spectrum disorder. However, other, like the alcohol-related neurodevelopmental disorder, 8 out of every 1,000 babies are born with that. So we can see that whereas the most severe form of alcohol affecting brain development only occurs in a small percentage of the kids in Oregon, we see that there are other ways in which alcohol consumption has affected individuals, resulting in developmental disorder. So challenges associated with FASD, well, mental health problems are associated with fetal alcohol spectrum disorder. FASD affects attention, it affects impulse control, it affects executive functioning skills. And so the kiddos are going to have a hard time achieving independence. They may become involved in criminal activity. Legal problems may lead to incarceration. Disrupted school experience, that's very likely that they will also be at risk for substance abuse problems, inappropriate sexual behavior, dependence, and unemployment. Appropriate services for youth on the fetal alcohol spectrum would be neuropsychological assessments to understand how to best assist them, early intervention, 0 to 3, special education services, parent and caregiver education, and these kids are going to need physical, speech, language, and occupational therapy services, as well as social skills training. So here's a slide that gives you some of the resources that I would recommend. There are books about fetal alcohol syndrome, and they're very good. And then the new NOFAS has become FASD United, and you can see the website on the slide. Next month, September, is FASD Awareness Month. And so you have the logo for that there. So youth with TBI, again, that is a problem for typically developing youth who sustain a traumatic brain injury. And one of the things that we know is that you can have a form of ADHD called secondary attention deficit hyperactivity disorder, which is a result of traumatic brain injury. Mood and thinking problems can also be the aftermath of brain injury, or what is sometimes referred to as neuropsychiatric disorders. Aggression, trauma, personality changes, and developing internalizing disorders have all been associated with the aftermath of a traumatic brain injury. So some strategies. The promotion of the use of the DMID2. So the NAD, the organization I mentioned earlier, which is also partnering with Oregon Health Authority to run these consultations, did publish in 2013 the DMID2, which is, maybe it was later than 2013. In any case, the DMID2, which is the Diagnostic Manual of Intellectual Disabilities, the second edition. And it is a very good tool to use to assist in diagnostic decision-making. So some other strategies includes increasing workforce capacity through a session like we have today, through training, consultation, and clinical supervision. By identifying medical conditions, which are highly co-occurring among youth with IDD, that may confuse understanding of behavioral challenges. So sometimes kids present with behavior issues because of pain, because of gastrointestinal issues. There are a number of medical problems that can complicate recognition of what's going on and might result in the child presenting with behavioral issues that are misunderstood. So very important to know about medical conditions that may co-occur with a person's IDD. And embedding trauma-informed care in all organizations and systems that serve youth with IDD. So I would be remiss if I didn't talk about the role of families. So most youth with IDD live with their families. And so it is when a child has an intellectual developmental disorder and mental health concerns, it is not only the individual who's affected, it's the entire family unit. So it's very important to gear interventions that not only are looking at supporting the family, but looking at understanding the family from a culturally appropriate lens. So we know that stressors on marriage with higher than average rates of divorce within couples who are parents to a child with IDD. We know there's increased incidence of maternal depression associated with having a child with IDD. The overall quality of life and level of distress is higher within the family, which includes the siblings that have a child with IDD as a relative, and a higher than average incidence of physical health problems associated with stressors involved in caring for youth with special needs. The best intervention for youth with IDD is an early intervention and one that is family-based. So the next several slides, I'm just going to overview some promising practices, some of which are very helpful for parents of young children. And I know that many of you are focusing on transitional age youth and children who are a little bit older, but I want to say that the importance of early intervention begins in supporting the parents at the very beginning. The Incredible Years Parent Training Program is an example of a model that's been extensively studied for the prevention and treatment of childhood conduct problems, and actually has been recommended as something that helps with mental health issues as well. It's typically delivered over the course of 12 weeks in a group format. Very often there are 8 to 12 parents in a group. And sessions typically cover things like play, praise, how to deliver rewards, how to set limits, and handling challenging behaviors. Skills are taught through group discussion, videotape vignettes of parent-child interactions. The parents have an opportunity to engage in role play. There are actually didactics and weekly homework assignments. And they have a modification of this parent training program called Incredible Years Parent Training-DD, in which includes using the toddler program curriculum due to the developmental level of the children, asking parents to identify key points that could be generalized to their children, and looking at what is applicable for them. So I recommend that if you're not familiar with it, that you really look to this possibility for parents of young kids with IDD. Another promising practice is parent-child interaction therapy, and it's an empirically supported intervention for children ages 2 to 7 with significant behavior problems. It's designed to change parent-child interactions and improve child behavior problems. And there are 2 phases to the treatment. One is child-directed interactions, and the other one is parent-directed interactions. And so, at your leisure, you can look into this. It's a very interesting form of therapy that is done with young children and their families. Last promising practice having to do with young kids that I want to bring up is a Stepping Stones Triple P model. It's part of the Triple P Positive Parenting Program series. It's designed for parents of children with developmental disabilities between the ages of 2 and 12. And it consists of 5 levels of intervention that cater to the level of support appropriate for different families. And they range from universal media campaigns to behavioral family interventions targeting child behavior and parent adjustment problems. So again, I think anything that supports the parent supports the youth. And here we're talking about interventions designed, excuse me, for very young children. Overall, a strategy for work with youth with IDD is social skills training, understanding what's the appropriate dress and decorum in different social situations, being able to differentiate acceptable forms of social interaction for different social occasions, knowing when to make eye contact and when to avert your eyes, determining when physical contact is acceptable, that is a handshake versus a hug, being able to politely start and stop conversations, being able to make small talk. So there are many ways, both verbal and nonverbal aspects of social communication that, we tend to think about kids on the spectrum having problems with this, but actually in general, kids with IDD, whether they are on the spectrum or not, very often benefit from social skills training. Understanding the difference between literal and figurative speech, when somebody is, using sarcasm or humor, and being able to express feelings and respond to the feelings of others. Another strategy to consider is the one that involves positive behavior supports. And positive behavior supports is like a first cousin to ABA, applied behavior analysis. And very often there are schools that adopt a version of this, which is PBIS, which is positive behavior in school kind of model. But it includes a range of intervention strategies that uses the least amount of intervention necessary. It builds and encourages positive behaviors, practical and adaptable to a variety of settings where behavior may need to be changed, and provides guidance to adapt the environment. So an example of some positive behavioral interventions are around creating daily positive routines, helping kids know how to request a break and when they may need a break, silent signals, proximity, like how do you use space when you're interacting with others, positive phrasing, and how do you, make behavior statements to a child that will help them and in terms of guiding their behavior. It's the idea is to promote the use of non-pharmacological intervention as the first response to behavior changes and challenges. And the idea behind positive behavior supports is to improve quality of life and reduce challenging behaviors. And you can use it with other things. For instance, I use positive behavior supports along with the Wellness Recovery Action Plan, which I will talk to you about in just a few slides. And the overall goal of this is to promote independence of the individual. And I provided you with the Association for Positive Behavior Support's website. So when we talk about psychotherapeutic techniques, I mentioned before, cognitive behavior therapy is one of the strategies or approaches that has been shown to be effective in work with individuals with IDD that have sufficient verbal skill. So obviously the child, the youth must have sufficient verbal skill in order to participate in cognitive behavior therapy. And there are modifications that have been developed so that it could be used with a population who have mild to moderate intellectual disability. And it might include a parent caregiver assisting with coaching and skills practice outside of session, using reinforcement and motivating factors to encourage participation, using very concrete examples to teach the various tools, tailoring teaching strategies to the person's developmental level. And again, you'll find information about this on the Complex MHIDD North Carolina site that I have listed on the bottom of the slide. Another form within the same family as cognitive behavior therapy is accepted commitment therapy, which has received a lot of attention, particularly in work with high-functioning individuals on the spectrum, those who have average or above average intelligence. And so this is about values and how one uses values to guide your behavior. Individuals are taught ways to distinguish between away moves, which keep them from goals, and towards moves, which bring them closer to their goals. The value of ACT is to work on psychological flexibility as we pursue solutions to everyday problems in terms of their workability. And I've given you another link that could help you understand whether ACT might be an appropriate psychotherapeutic approach for a client with a youth with IDD. So now on to some tools. My personal favorite is the Wellness Recovery Action Plan. Many of you have used the WRAP for youth without intellectual developmental disabilities. However, Mary Ellen Copeland and the Copeland Center has developed a WRAP workbook for people with developmental distinctions. The toolkit is used within mental health to address what the individual with mental health concerns can do daily to improve their functioning. And you can do this with the youth, or you could do it with the youth and their family. It is also possible for the family to fill out a separate WRAP. And again, it's, what are their coping skills? What does a good day look like? What does a bad day look like? How do you get to a good day? Very practical and oriented to self-help. I also like the incredible 5-point scale. It's a tool to help youth link feelings with behaviors, where they rate where they are in terms of their feeling. Very often it's used to kind of identify level of anger and anger management, or level of stress in terms of stress management. And children are encouraged to identify what events can lower their level of stress and anger. The tool can be used in the school, in the community, in programming, and by families. And it's supposed to help with self-monitoring and improve self-regulation. And it's used with the general population, not just with individuals with intellectual and developmental disabilities. So this is an example where a tool that you may already be familiar with can be applied to your work with youth with IDD. Zones of regulation, probably pretty familiar with that. And this is emotional education and regulation. It can be used within the school setting or community programs, and can be adopted for use by families of youth with IDD. And here again, we're using color coding. Blue zone refers to kind of sad, sick, tired, bored, or moving slowly. Green zone, happy, calm, feeling okay, focused, ready to learn. Yellow zone, frustrated, worried, silly, wiggly, excited, loss of some control. And red zone, mad, angry, terrified, yelling, hitting, elated, out of control. And the idea is to get to the green zone. How do you get to the green zone? Still working on that one myself. But I have found this very useful in work with my work with youth with IDD. So what are some of the take-home lessons that we have, or take-home messages? So youth with IDD do have similar mental health concerns as do typically developing youth. However, we have to consider their neurodevelopmental disorder as we think about the approaches, tools, and strategies we might use with them. So definitely use clinical approaches, strategies, and tools with modifications. And because we do not have at this point in time particular tools that are expressly designed for individuals with IDD and have been empirically tested as such. Know the nature of the neurodevelopmental disorder of the youth you're treating. ID, autism spectrum disorder, cerebral palsy, seizure disorder, fetal alcohol spectrum disorder, traumatic brain injury, whatever might be there are a number of chromosomal conditions, whether it's Down syndrome or Williams syndrome, or there are any number of conditions that a child might have that would impact upon what appears to be a mental health presentation. So you have the clinical skills. Now the idea is pursue the coursework and the training and the case consultation and the clinical supervision that will help you grow your competencies in your work with youth with IDD. And as you probably figured I was going to tell you to do, join NAD, because it is an excellent resource. I get no commission for telling you to become a member. Advocate for early intervention. You don't want to be in a situation where the child at age 17, the youth, is first receiving services and has not, that's 17 years or thereabouts, where there's been lost opportunity to intervene with the youth and their family. So as early as one can to intervene to get help to the child and the family, the better off the entire family unit will be. And definitely seek models of parental support, of sibling support, because mostly youth live with their families. And what impacts them impacts the entire family. Very important to provide scaffolding to the family while we're providing scaffolding to the child. So I've provided some references of the things that I have spoken about. And at this point in time, I would like to see if there are any questions or have a discussion with you.
Hi, Roberta. It looks like your hand is raised.
So I was just wondering, I noticed you refer to a lot of behaviorist type references and supports, which are more about changing the youth with IDD's behaviors before the mental health supports can be put in place. But you didn't mention anything about collaborative problem solving, which allows the youth to be treated as a person first and to be involved with their diagnosis and how to get the mental health services and advocate for themselves. So I was just wondering why that is not included. Is NAD anti-CPS or?
Of course not.
Oh, okay. It isn't mentioned at all in here. That's why I'm asking.
Right. Well, there probably are several things that are not mentioned in here, but thank you for raising that, for lifting that up. Very important. I would say that it is extremely important to do. My experience is that it's not been utilized, and whereas some of these other approaches have been utilized. Huh?
And there are a lot of people who have autism who have created great PTSD in their lives because of schools and providers trying to force their behaviors to change before they can get those mental health supports, which is you know, why children don't do well if they're being told what to do, because we're not in the army, we're parents. And so that's all. I just wanted to put it out there. CPS was pretty life-changing for our family, and we were calling the police every day for years, and then we apply CPS and suddenly we haven't had to call them in a year. So I
That's
just
great.
wanted to say it's another alternative that's available.
Absolutely, absolutely. And this is not meant to be the definitive list of all things that can be done. And the thing about behavior that I'm just going to point out is most individuals are brought to the attention, whether it's to mental health or to their doctor or wherever, because of behavioral issues. And so, yeah, and that is unfortunate. And it means that it obscures a lot of mental health and medical and other problems that are going on. Absolutely.
I think Bernardino, you had your hand up next.
Yeah, thank you. I just want to say, first of all, Lucy, thank you very much for all this information. You had really great information and different angles for this population. I'm mostly work with the substance abuse disorder youth and young adults, and I'm always at a loss, really. And I'm really glad that you put in those slides in there around substance abuse, and then you also talked about cognitive behavioral therapy. Because in the substance abuse world, you know, when I get youth that are IDD and they get rejected from outpatient or residential treatment, saying, hey, we can't work with this youth because, you know, he can't comprehend these concepts, and they do use CBT. And so I found it interesting that you talk about CBT with this population, and then also the substance abuse. I'm at a loss, like what services can we really provide for this population with substance use issues? And I almost think about, like, maybe we need to have a conversation or discussion around really looking at opening up a facility to really work with this population that are using substances. And I really don't know the answer, but I was found it intriguing that you had that information in your slides, and wondered if you could share more, like what can be done, or what can one say to people that say, hey, you know, they won't take my kid to treatment, and are there any other options?
Yeah. Well, I mean, I think that's been my experience too, that most of the youth that have substance use challenges have been rejected from, you know, more traditional programs. And the CBT has been modified, so it can be used with individuals, youth who have either mild to moderate intellectual disability. It depends on their verbal skills. And so, so I would be less concerned by IQ per se, and more concerned with the person's verbal ability and ability to communicate, as well as to understand communication. And very concrete examples are used as a way to help deliver some of these concepts. The other thing that is used is motivational interviewing, and adapted to the population. Again, when I say adapted, it has to be adapted to the developmental level of the individual, what they understand, where they are, what they can grasp, what are they interested in. And so those are things. And I think that there probably, first of all, there's a need to study substance use and understand it better among people with IDD, youth and adults. And then that could help us lead the way to more specific treatments that may be effective. In the meantime, I think we have to use what we have. And people should be encouraged to either have a specialized track if they need to, that would include youth with IDD, or in some way recognize that these kids are not only needing treatment, they're entitled to treatment.
Right.
They're entitled to it.
Right.
Yeah. So those are, you know, other than to commiserate with you, because I understand exactly what you're saying, Those are my thoughts about it.
Thank you very much.
Jenny, it looks like your hand is up next.
Yes, thank you. Yeah, so I guess first of all, I want to say my son, I'm the parent of a 27-year-old man who is autistic and blind and has profound communication challenges, doesn't have the ability to converse. I adapted cognitive behavioral therapy and it worked for him. I do not agree. He's also diagnosed as severe. I do not agree that it isn't accessible to non-speaking autistics. I think that we need to presume competence. And also, I think that ableism often plays into the mental health challenges that developmentally disabled and intellectually disabled people experience. And so really being aware, I know we're all learning and growing together. Experience who are intellectually and developmentally disabled, who are speaking up and saying, please don't treat us as behavior problems. Stop trying to modify our behaviors when our behavior is a reaction to an ableist society that doesn't treat us like human beings.
Right, right. Yeah, thank you for sharing that.
Roberta?
So I was going to type it up, but it's just easier to say it. So I have a autistic teenager who is IDD, who experiences mental and behavioral health challenges. And a year ago, he tried to attempt suicide and he needed psychiatric unit. And because of him being in pull-ups and requiring what the hospital said was a nurse on staff to help him should he have that need, he was denied services, psychiatric unit services. And so there's a lot of discrimination against youth with IDD because mental and behavioral health say, well, we don't know how to deal with the DD part. And then when we go to the DD side, they say, well, we can do the DD, but we can't do mental and behavioral. So there's a hugely marginalized group of youth here in Oregon who cannot access any mental health, behavioral health, acute and subacute care because they do also have medical needs. And so I was wondering if that's something that you were planning to address today.
I wasn't going to address that today, but I'll address it since you brought it up. Okay, so that there are some places that there are models in which there are specialized units, psychiatric inpatient units, that are able to accommodate on short-term basis individuals who have co-occurring medical as well as psychiatric needs. And I agree with you, the traditional it's a bifurcation for the general population as well. Like if you have a physical problem, if you are in a wheelchair and you need to be in for whatever reason, and you need a hospital stay, that could become a big issue that would prevent you from being hospitalized. Yeah. So in New Jersey, for instance, and a couple of other places, and the reason I know that is that I worked in the hospital that had this specialized unit, and they began with an adult unit of 6 beds. Then they eventually went up to 20 beds. And then they had a child unit that also was a 20-bed unit eventually. And there they were able to accommodate not all, but many of the things. For instance, if somebody were in pull-ups or somebody they certainly don't need nursing care for that. So there were ways that they were able to accommodate that on the unit. Clearly not all states have that. Oregon doesn't seem to have that. Other than to kind of put pressure and to say that that is what is needed, something specialized that would at least allow for treatment of people who have co-occurring challenges. Yeah.
Yep, thank you.
Any other questions?
Mm.
Comments? Any? Great. Well, I guess we'll give a few minutes back to folks' days, and I appreciate everybody being here. I appreciate the conversation and the openness and comments and questions. So we will do another consultation on the third Thursday of next month. I'm not completely confirmed on what the topic is next month. We're still working on getting that all lined up, but we will be here again on, I believe it's September 21st is the date. It's the third Thursday at 1 o'clock. So I hope to see folks next month. Thanks so much.
Bye-bye.
Bye.
Thank you.
Will it be NAD again next month or someone else?
It is, yeah, the contract we have is for NAD to do all of these. So it will be somebody within the NAD sphere, which is a very large network of folks.